Good morning, everyone. Today we will be talking about ultrasound in urology. Ultrasound is considered to be one of the most basic investigation in urology. The advantages are it is cheap, easily available, and it is relatively safe. Ultrasound can also be considered as the stethoscope of the urologist, just like you have the stethoscope which a cardiologist or a physician uses. An ultrasound machine, it can be considered like a stethoscope. So why do we prefer ultrasound? Because it is safe, cheap, portable, easily available, and any urology resident or a consultant can do the procedure by himself, and the information which he gets from there can add to his clinical examination. We will start with a brief history of ultrasound. Ultrasound was used for imaging urological pathology since 1955, but because the resolution was not good, no one attempted and not much information was available at that time. In 1963, Takahashi and Uchi tried imaging the prostate. In 1974, Watanabe, he used radial scanning and successfully demonstrated truss. This is a picture. This chair, which is shown in the image, Watanabe chair, it includes the probe goes into the rectum and then the imaging is done. This is an image of the benign prostate and this is an image of the malignant prostate. But because the resolution was not good, it was not followed for long. In 1971, Goldberg and Pollack used amplitude mode for differentiating renal masses. Amplitude of wave is a maximal excursion of the wave in the positive or the negative direction. Sound waves are sine waves. So in this image, this is the amplitude of the wave. The amplitude of each returning echo decreases over time due to ultrasound attenuation. A mode or amplitude mode, it measures the distance between two objects or thickness of tissues over time. This is an image showing A mode ultrasound. This is a transducer which produces the waves and also acts as a receiver. Imagine this is a tissue having multiple layers. So when the waves strike the first interface, the amplitude of the returning waves is higher. When they go to the second tissue or interface, they are lower, and third, they are still lower as compared to the first and the second. So this amplitude, A mode, is more commonly used for imaging of the cornea, lens, etc. The other mode is B mode or brightness mode. B mode or brightness mode, it represents the amplitude peaks which are seen in A mode as dots or pixels of varying brightness. The brightness of the dot depends upon the amplitude and the location of the dot depends upon the distance from the transducer. B mode is the most commonly used mode. Here is a pictorial representation. This is the A mode. The transducer is here, so which is here, and then the amplitude of this dot is higher. It means this is the first interface. This is the lowest. It means it is the last interface. And in B mode, the distance of the dot shows the distance from the transducer. M mode is used for assessing movement. It is most commonly used in cardiac ultrasound. This is an image of the M mode. Here this graph is analyzed and it gives an information about the motion. In 1974, Hall and Northwest introduced a transurethral ultrasonic device. They wanted to simultaneously scan the prostate and also interchange it with some device which can do resection of the prostate. But because it was too cumbersome, it did not succeed. In 1976, Perry used ultrasound to assess the acute scrotum. In 1976, Watanabe used Doppler to assess the renal artery blood flow. In 2010, Chen et al. Used the ultrasound machine to inject botulinum toxin into the external urethral sphincters for DESD. Ozawa et al. In 2010 used transperineal ultrasound to perform a video urodynamics. Because urodynamics is more invasive, they wanted to show whether it is possible to do urodynamics without using invasive catheters. Here they use the Bernoulli principle and they perform the video urodynamics. Coming to the basic physics, sound waves are longitudinal waves. Whenever longitudinal wave means it travels in the form of compression and rarefaction. This is how longitudinal waves travel. Now, compression means the waves are very close to each other. Rarefaction means the particles are very far away from each other. This is the basic principle. Sound waves travel with different speeds in different objects. In air, the speed of sound is 330 meters per second, whereas in human tissue, it is roughly considered to be 1540 meters per second. Because sound waves are longitudinal waves, there is a drawback because of this property. As the frequency of the sound wave increases, the resolution decreases. When you have to evaluate different structures, for example, the scrotum, you need to use a different probe, whereas when you want to evaluate the intra-abdominal organs, you need to use a different probe. Transducer technology. Transducers works using the principle of piezoelectric effect. What is piezoelectric effect? Piezoelectric effect utilizes the property of certain materials that produce electricity when they are deformed. This is piezoelectric effect. And the reverse is reverse piezoelectric effect. When sound is mechanical energy is applied, they produce energy. So coming to the transducer technology. Transducer technology, it uses piezoelectric effect. It is the effect of certain materials to generate an electric charge due to an applied mechanical stress. So piezoelectric crystals convert electrical into mechanical energy. So modern transducers come in various sizes and shapes, and they are used for different purposes. This is a general principle of how ultrasound machine works. This is the transducer. 99% of the time, the transducer acts as a receiver. There is a clock in the machine which it is a master clock. It produces pulses are generated depending on the clock, and then the clock calculates the time taken for the sound waves to go to the tissue and also return. And when these sound waves come back, depending upon the sound waves, they are processed, and then the final output is given like this. So there are different kinds of transducers. Now, one transducer cannot be used for all purposes. So what are the different kinds of transducers? This is a linear transducer. It has got a flat rectangular footprint. So when you see an ultrasound image which has got a rectangle or a straight line, it means it is a linear transducer. Linear transducer, it uses high frequencies. It is used for examination of the scrotum, testis, and superficial structures. We cannot assess the deeper structures because, as we already know, that as the frequency increases, the depth of penetration and the resolution decreases. This is a convex transducer. Here you can see that the footprint is convex. This is the transducer which we use most commonly in urology and any abdominal examination. The frequency ranges from 2.2 to 7.5 megahertz, and it is used for kidneys, bladder, any intestinal pathology evaluation. Now, when we have to evaluate any intracavitary structures like the prostate, or when we have to do transrectal examination, or you have to do transvaginal examination, we have something called as an endocavitary probe. Endocavitary probes, they have a hemispherical cut section. The frequency is 3.5 to 11.5 megahertz, and applications are, like already told you, test for prostate either for diagnostic or for biopsy purposes. Now here, this is a pencil shaped transducer. It cannot give any images, but it will only show the Doppler. This can be used to assess the renal artery for renal artery stenosis. Its frequency varies from 2 to 8 megahertz. This is a phased array transducer. It has a very narrow cross section, and the cross section looks like a sector, and it is used for cardiac imaging. So whenever your cardiologist does the 2D echo, he uses this type of transducer. This is a picture of a transesophageal echo where it is just given for academic purposes. Here it is used for evaluating the cardiac motion. Now coming to advances in ultrasound, there is something called as 3D and 4D ultrasound. Normally when we do ultrasound, it gives only a 2D imaging. Now newer transducers, they can give volumetric data. The 2D images are acquired in multiple dimensions and the system processes them and we get a 3D image. Now what is 4D image? 4D image is also when you add the, it is real-time dynamic 3D imaging. It is used for assessing the cardiac structures. So this is just a chart showing all the transducers and their comparison. Multiple times I spoke about resolution. Now let us know what is resolution. Resolution is the ability to differentiate between two objects which are close to each other. Resolution is of two types: axial resolution and lateral resolution. Axial resolution is the ability to identify two objects which are close together but in the same line. So this is axial resolution. Lateral resolution is the ability to identify two objects which are equidistant from the transducer. So resolution depends upon the focused width of the ultrasound beam. So this is the transducer and this is the focused width. So if you want to identify two objects which are very close to each other, you should decrease the focal zone as it becomes narrow. We will have more information regarding the lateral resolution. Whenever sound waves travel to any tissue, there will be loss of energy. This loss of energy is called as attenuation. What are the mechanisms by which attenuation occurs? Why is this important? Because attenuation also can cause the tissues to be misinterpreted. So attenuation occurs because of reflection. Reflection when the waves strike the boundary of an object and they are reflected away. This depends upon the angle of the transducer in which the transducer is placed. This reflection can be controlled by changing the direction of the insonation. It also depends upon impedance. Impedance is the difference in the echogenicity of two different tissues which are close to each other. For example, we can have the kidney and the gerota. The kidney is much more dense, whereas the gerota is slightly less denser in terms of echogenicity. So because of this impedance difference, we are able to identify different textures of the tissues. And one more way of attenuation is absorption, and last is interference. So here the transducer is producing waves, and here there is an object which is cystic. It is a low attenuating structure. Because it is low attenuating, the waves which pass through it have more energy when they reach the far wall of the cyst. So behind this, even though the tissue has similar echogenicity as compared to the rest of the tissue, it looks hyperechogenic. So if you know the property of attenuation, then you will not misinterpret. Then there is some structure which is having more echogenicity. For example, a renal calculus. Because all the sound waves come and they are reflected back. There are no sound waves which are passing behind. So there is something called as post-acoustic shadowing. Because of post-acoustic shadowing, even though the calculus is spherical or it has any other shape, it looks crescentic. So it should not be mistaken as a crescentic calculus. One more type of attenuation occurs because of scattering. When sound waves strike multiple small objects, the waves are scattered in different directions, and depending upon whether they are in phase or out phase, they give different kind of image. This scattering is most commonly seen in the testis. This is also called as speckling artifact. It is appearance of a normal. One more kind of attenuation is scattering. In scattering, the sound waves strike multiple small objects simultaneously and they are reflected in different directions. And depending upon the way they are reflected, the waves can either be in phase or out phase. This, whether it is in phase or out phase, can give rise to artifact which is called as speckling artifact. This speckling artifact is most commonly seen in testis. It is normal and nothing to be worried of, unless and until you see there is something called as microlithiasis. We will discuss about microlithiasis subsequently. Absorption is also one of the mode of attenuation. When sound waves are absorbed, it leads to production of heat. The amount of heat generated depends upon the frequency of the probe and how long the probe has been used. Now, when there is attenuation, how can we overcome attenuation? Attenuation can be overcome by techniques called beam steering and focusing. What is beam steering? In beam steering, without moving the direction, moving the probe or changing the direction of insonation, electronically the beam insonation is changed. This is called as beam steering. It helps to improve the lateral resolution. Tapering, in tapering, gradually towards the periphery of the field, the amplitude is changed so that the margins of the structure are well defined. Beam steering and focusing are more important for truss imaging. Resistive index, I will be discussing about this in Doppler section, but just let us know that the normal resistive index for renal arteries varies from 0.4 to 0.7. Now coming to artifacts. Artifacts are generated because of interaction of sound waves with tissues in different ways. Now what are the kinds of artifacts? One is reverberation artifact. Reverberation artifact occurs when sound waves strike objects with two different impedances. For example, when sound waves strike bowel, like we all know, it contains gas and liquid. So when sound waves travel, they first strike the gas and then they go to the liquid. So the difference in impedance between gas and liquid is very high. So the sound waves, again they get reflected from the liquid, go back to the gas, and again they keep continuing in this manner. So the images which are produced will have multiple layers. This is an example of multiple lines because of reverberation artifact. These lines, this is all because of reverberation artifact. Acoustic shadowing, it occurs because the calculus has high impedance and all the waves which come here are reflected back. So there are no waves left to travel posteriorly. So this leads to post-acoustic shadowing. This can be mitigated by changing the direction of insonation. Increased through transmission. This occurs because when sound waves pass through fluid containing cavities, the sound waves which pass through the cavity, when they reach the far wall of the cavity, have more energy, and subsequently the tissues posteriorly will be hyperechoic. Edging, it occurs because the sound waves at the edge of a curved surface are refracted, and because of edging, the exact size will not be known. So this can be corrected by changing the angle of insonation. Coming to the modes of ultrasound. We already know A mode, B mode, M mode. They are the common modes. What are the modes which we use in our practice? As a urologist, we most commonly use gray mode. Gray mode ultrasound is B mode ultrasound scan. Then there is something called as Doppler ultrasound. Doppler ultrasound uses the principle of change in frequency of a wave depending upon whether the particles are moving towards or away from the transducer. For example, here you can see that the RBCs in this picture are moving towards the transducer. So the amplitude of the wave here is high. In this image, we can see that the blood is going away from the transducer. So the amplitude of these waves will be low. What are the types of Doppler? Doppler has there are multiple types of Doppler, and each Doppler has different functions. There is continuous Doppler, spectral Doppler, power Doppler. Color Doppler, it evaluates the blood flow, the direction and the velocity. By convention, when blood is flowing towards the transducer, it is given a red color, and when blood is flowing away from the transducer, it is given a blue color. So here a color Doppler is showing blood from the renal artery is going towards the cortex, and blood from the cortex is coming through the veins into the renal vein. Color Doppler can evaluate presence or absence of blood flow. In this image, we can see that blood which is going from the renal artery towards the cortex, it is going towards the transducer. It is shown in red color. Blood from the veins is going away from the transducer, so it is shown in blue color. Where can we use color Doppler? We can use color Doppler to assess whether there is blood flow to an organ or no. For example, in testicular torsion, in renal transplant, etc. Color Doppler, we cannot calculate the pattern of the flow. We can only come to know whether there is flow or no. The next kind of Doppler is color with spectral display. In spectral display, we can evaluate the pattern and also the velocity. This was not possible in just color Doppler. In spectral display, we can calculate the resistive index. Resistive index is peak systolic velocity minus end diastolic velocity divided by peak systolic velocity. I already told you the normal range is from 0.4 to 0.7. This is very important when you are assessing renal transplant patients. If the resistive index increases, it means there is some cause for the renal graft to malfunction, and it has to be evaluated immediately. It can be acute rejection or chronic rejection. The next Doppler is power Doppler. Power Doppler gives us an idea of only the perfusion to tissues. Either the perfusion is there or not there. It does not give any idea about the direction of flow. This is important. It is better actually when you compare to color Doppler because there is less amount of artifacts in this. This is a picture which shows power Doppler. It only shows the presence of blood flow. It does not show the direction of blood flow or how much blood is flowing where. This picture shows a comparison between color Doppler versus power Doppler. Color Doppler shows the direction, whereas power Doppler just shows the presence of blood flow. Sometimes during imaging, there will be a lot of noise which leads to artifacts. So this can be optimized by adjusting the depth, focus zone, and gain to balance the contrast and penetration of the ultrasound waves. One more kind of imaging is called harmonic imaging. This harmonic imaging is more used in contrast ultrasound. Harmonic imaging uses harmonic. A harmonic of a wave is a multiple of the wave. So normally if for ultrasound we use a wave with a frequency f, in harmonics we use the frequency with 2f. When waves with such high frequency strike tissues, the returning waves will have a frequency of f, whereas in the normal ultrasound they will have a frequency of f by 2. So the image produced by this is slightly inferior when compared to this. Spatial compounding. Here the direction of insonation is electronically changed to get better imaging. It is used in Peyronie's plaques and renal cysts. Sonoelastography. This uses the principle that whenever a given force is applied to any tissue, the deformation of that tissue depends upon how soft or hard that tissue is. So suppose a given force F is applied to a tissue T. If it is hard, the deformation produced will be lesser, whereas the deformation produced is more if the tissue is softer. So this is the basic principle. So sound waves are compressing mechanical waves. When these waves are applied to any tissue, they will cause deformation. So now sonoelastography, there are two types. One is real time elastography and the other is shear wave elastography. Real time elastography, the sonologist himself applies pressure and then these waves are transmitted and they are processed, and after processing an image is created. Real time elastography is only qualitative. It will not give objective data, and the image which is produced it has to be labeled by the sonologist. Not all images mean the same thing. This is an image where the real-time elastography is showing is assessing a lesion in the prostate which turned out to be malignant. Shear wave elastography. Shear wave depends on the principle of tangential sliding of tissue on application of force. So these waves are slower and hence the returning waves are also weaker, and hence we cannot assess much deeper tissues. So shear wave elastography uses the principle elasticity equals 3 into density into c square, where c is the wave propagation speed. Shear wave elastography correlates with fibrosis or malignancy. If prostate lesions are having more than 100 kilopascals, usually they are malignant. This can help in targeting for tissue biopsy. This is a shear wave imaging of the prostate, which shows a lesion here which was targeted and it turned out to be malignant, which a target biopsy was done and turned out to be malignant. A new concept is coming which is called as multiparametric ultrasound. They are trying to replace or use ultrasound in place of multiparametric MRI. This is because MRI has some limitations which can be overcome with ultrasound. Ultrasound is easily available, can be and has not many limitations, whereas MRI you need to go for the machine. The machine setup is costly. Then MRI you cannot do in-bore biopsy, which is difficult. The differences of multiparametric ultrasound versus multiparametric prostate. The anatomic resolution of ultrasound is lower, 2.3 mm versus 1 mm. So MRI is better. Vascularity, here we can use microbubbles and a contrast enhanced ultrasound. So this is better and much easier. No problem of renal insufficiency. Whereas the gadolinium which is used in MRI can cause SNF, nephrogenic systemic fibrosis. The tissue structure in ultrasound, we can use either strain elastography or shear wave elastography. In MRI, we use water diffusion. Chemical characteristics of the tissue we cannot identify in ultrasound, but on the MRI we can have choline spectroscopy, which will give us the composition of the tissues. Access for biopsy in ultrasound is unlimited, whereas in MRI there is some limitations. Contrast in ultrasound. The contrast in ultrasound is usually a gas coated with some material. This contrast is can be either injected into the blood or we can directly inject it into the tissue. The most commonly used contrast is perfluorine, PFCs. The contrast which is used most commonly is perfluorine. It is a gas in a lipid microsphere. This contrast can be either injected directly into the tissues or it can be injected into the vasculature, and it goes to the tissue of interest where it is assessed. This uses a principle of harmonic ultrasound. The contrast which is used is absorbed and then it goes to the lungs and broken down in the lungs and it is exhaled. So now what are the contraindications for contrast ultrasound? One is patient who is having any asthma or acute myocardial infarction or emphysema. This is a picture showing multiple generations of contrast ultrasound materials. The latest generation is where we use the gas which is nitrogen, perfluorine, perfluorocarbons, and the shell is made up of protein or lipid. There are multiple which are in trial, but they are not yet available for general use. This is an image in the Greyscale which appears like a tumor. On color Doppler, it showed increased vascularity. Again, it goes in favor of a tumor. But when contrast ultrasound was done, it was seen that there was not much of increased vascularity, and hence a diagnosis of a renal pseudotumor was made. What are the uses of contrast enhanced ultrasound? Renal IV injection, we can assess the blood flow. We can assess the intraoperative efficacy of cryoablation. Solid tumor surveillance can be done, and to assess the pelvic calyceal system, direct injection into the pelvic calyceal system can be made. This can be used during after PCNL to do ultrasound guided stent insertion. It is used in pediatrics to assess reflux, to check ureteral patency after PCNL. Coming to patient safety, we started with the premise that ultrasound is safe. That is true. But how safe it is? Ultrasound uses sound, which is sound waves, and these sound waves carry some energy, like we already learned during attenuation. So now these sound waves can have some effects. The effects can be mechanical and thermal. Mechanical effects are torque and streaming. Because of mechanical effects, there will be multiple microbubbles formed. These microbubbles, they collapse, and when they collapse, they release a large amount of energy locally. This large amount of energy can cause destruction of the tissues. This is the same principle which was used earlier in ESWL, extracorporeal shock wave lithotripsy. So here is a cavitation bubble being formed. It is collapsing on itself, and it has collapsed and it has ruptured. The thermal effect of ultrasound, it produces heat. This thermal effect of ultrasound, which produces heat, is being used to put in high intensity focused ultrasound. It is being used to treat prostate cancers. So each ultrasound machine has something called as ODS, output display standard. It shows mechanical index and the thermal index. These are not safety values. They are just indices which tell us how much of a risk is there to the tissue being examined. For stabilized gas bodies like the intestine, it is 0.7. It is less than 0.7. If it is less than 0.7, we can continue examination. If the index increases, then it is better to avoid examination in that area for some time. Thermal index, it calculates the risk that scanning a particular area will lead to an increase in temperature of that tissue by 1 degree centigrade. So if the thermal index rises by is 6, then you have to stop scanning. Now coming to how to perform the ultrasound. Renal ultrasound, we use the curvilinear probe. The patient is in the supine position, exposed from the xiphisternum to the iliac crest, and then the curvilinear probe is used and it is kept at the mid-axillary line. By convention, the image which is shown, the cranial, the upper part of the image by convention is considered to be the upper pole. What are the indications for renal ultrasound? One is routine evaluation. Whenever a patient comes in the clinic, you examine for any stones, any hydronephrosis. It can be used for in the surgery, it can be used for ultrasound guided PCN insertion, or it can be used as a first step during PCNL. A normal adult kidney is 10 to 12 centimeters in length and around 4 to 5 centimeters in thickness, with a cortical thickness measuring up to 1 centimeter. The renal cortex is hypoechoic. When you say hypoechoic, it is compared with the liver. How do we use ultrasound in interventions? When we want to do a percutaneous nephrostomy, or we want to puncture the kidney for PCNL, ultrasound will help us in guiding the direction of the needle, and it can also give real-time location of the colon, and the colon can be avoided. The principle which is used here is hydrophilic wires are visible, and when the polyurethane dilator goes on top of the wire, the echo of the hydrophilic wire disappears. This means this gives us the approximate location of the polyurethane dilator. So what are the limitations of ultrasound? Ultrasound, the skin to stone distance. For example, if the patient is obese, it is difficult for the waves to go so deep, and the images produced are not as clear. Then if there is absence of hydronephrosis, then staghorn stones, poor echogenicity of the kidney. These are all limitations because ultrasound uses a principle of varying echogenicity of tissues to identify the best tissues. Ultrasound uses the principle of varying echogenicity to identify which tissue is what. Ultrasound guided renal biopsy can be done. It has been shown that It is not the number of passes of the needle which cause complications, but it is the BP at the time of ultrasound can be used to do renal biopsy. It has been shown that it is not the number of passes that cause complications. It is the BP at the time of the procedure which causes more complications. Now coming to transabdominal pelvic ultrasound. Transabdominal ultrasound will give information about the abdominal organs. We as urologists, we look at the bladder, prostate, seminal vesicles, and if it is a female, we can also look at the ovaries and the surrounding structures. Transabdominal ultrasound. It gives us information regarding the abdominal organs that are located in the pelvis, that is the bladder, prostate, seminal vesicles, etc. In the bladder, we can assess the amount of bladder filling, the thickness of the bladder wall, presence or absence of floating echoes, presence or absence of clots. Prostate, the size, any calcifications, any areas which appear malignant. Then we can also assess the surrounding structures. In males, the seminal vesicles, and in females, the uterus, ovaries, etc. The calculated bladder volume with ultrasound is usually within 10 to 20% of the actual volume. This is ultrasound showing the prostate. This is the sagittal section of the same prostate. To evaluate the testis, we use the linear probe, that is a high frequency probe. We assess the size of the testis, any calcifications are present. Microcalcifications are calcifications which are less than 1 mm. They are considered to be a precursor for malignancy. Then testis evaluation is important in for malignancies. Evaluation of the testis is important for benign conditions like hydrocele, emergency like torsion, malignancies, then infertility evaluation where we assess the size of the testis, etc. It has also been shown that sonoelastography is helpful in evaluation of infertility. By sonoelastography, we can identify the probable site of spermatogenesis. The testicular volume is normal is about 6 ml. It is calculated by the formula length into width into height into 0.5. In torsion, there is absent testicular flow, whereas in epididymitis, there is hyperemia. Microlithiasis, it is seen as bright non-shadowing foci. Varicocele. Varicocele are dilated pampiniform plexus of veins. Varicocele, patients usually present either of two ways. One, they present for evaluation of infertility or as chronic orchialgia. So the definition of a varicocele is if the pampiniform plexus of veins is more than 2.5 mm. There is several gradings and several ways of assessing the varicocele. It is clinical and ultrasound based. The clinical grading is subclinical, and there is non-palpable varicocele identified only on imaging. Grade 1, varicocele is palpable only with Valsalva. Grade 2, varicocele is palpable without Valsalva. Grade 3, there is a bag of worms appearance. This is a Sateshi grading which uses ultrasound findings. It uses in ultrasound findings, Sateshi grading looks at the level of the reflux and scrotal deformation and presence or absence of testicular hypertrophy. Evaluation of the penis and urethra. Ultrasound can be used to assess the penis for any Peyronie's plaques or any curvature or any other deformities. It can also be used to assess penile fracture. It uses high frequency 12 to 18 megahertz linear array probe. The linear array probe can also be used to assess transperineally the bulbocavernosus muscle thickness, and the bulbocavernosus muscle thickness has been shown to correlate with free and total testosterone levels, and it is being evaluated as an indirect marker for fertility. Ultrasound Doppler can also be used for assessment of erectile dysfunction. The normal velocity, normal peak systolic velocity of the cavernosal arteries is more than 25 centimeters per second. If it is less than that, it can be a cause for arteriogenic erectile dysfunction. Other imaging markers on ultrasound for arteriogenic ED are cavernosal artery dilatation less than 75% and acceleration time more than 110 milliseconds. Equivocal values are if the PSV is between 25 and 35 centimeters per second. These values are after injection of vasoactive substance. And if there is after injection of vasoactive substance like piperine, if there is a difference in the say PSV of both the cavernosal arteries by 10 centimeters per second, or there is any focal stenosis of the cavernosal artery, or there is a reversal of the cavernosal and corporal blood flow, it means that the patient may be having arteriogenic erectile dysfunction. So normal values of a penile Doppler after vasoactive drug injection, it is more than 30 centimeters per second is considered to be normal. If it is less than 25 centimeters per second, it is arterial insufficiency. This data we can use to plan the treatment. A patient who is having normal or equivocal values can be managed medically. He most likely does not have arteriogenic erectile dysfunction. A patient who has arteriogenic erectile dysfunction will not be benefited by medical treatment. He needs surgical treatment like implants. This is a picture of a transperineal ultrasound in females. This transperineal ultrasound, as a urologist in females, we use it to assess the amount of prolapse or amount of descent of the urethra in patients who have stress urinary incontinence. Ultrasound can be used for evaluation of the renal transplant. It will show the direction of blood flow, and the most important value is the resistive index. If the resistive index increases above 0.7, it means that the graft is going for rejection or there is some cause which needs to be evaluated. It can also assess routinely any presence of any hematoma, lymphocele, urinoma, etc. Prostate imaging, transrectal ultrasound of the prostate. We use an endocavitary probe. Endocavitary probes can be end firing or side firing. Different machines have different types of probes. So, what are the contraindications for TRUS? Contraindications are patient is having painful rectal conditions like a fissure or any abscess, any rectal mass or any lesions. In ultrasound, we all know that the prostate has peripheral zone and the central zone. In ultrasound, the peripheral zone is hypoechoic and the transition zone is heterogeneous. Heterogeneous in BPH. The prostate volume is similarly calculated length into width into height into 0.5. This is an image of a TRUS image showing the transition zone. There are some intraprostatic calculi. This is the peripheral zone. This is an image showing a transrectal ultrasound biopsy. Here, along the probe, the needle is injected. We target the focus and then the abnormal focus, and then tissue is taken from there and sent for biopsy. TRUS biopsy technique: first, patient is explained the procedure, consent is taken, check for parameters like any bleeding diathesis. Then the patient is put in the left rectal position, and then with the probe, and then with the along the probe, each transrectal probe has a needle guide. Along the needle guide, the needle is inserted, and this can be followed. The needle can be followed in real time, so you can know the exact site from where you are taking the biopsy. So it is targeted. The needle guide can be followed during the procedure, and we can target the site from where we are taking the biopsies. And after the biopsy, you check for hematoma. Special populations are pregnancy and pediatrics, where ultrasound is very useful. Pregnancy, where suppose there is a patient who has ureteric calculus in pregnancy and we want to stent. In such patients, we cannot use ultrasound. We have to use Suppose there is a pregnant lady who has a calculus and we want to stent or we want to assess her. Such patients, we cannot use radiation. In such situations, ultrasound is very useful. It can also be used to stent the patient and check the position of the stent. Pediatrics, or because the children are small, the images that are obtained in pediatrics are much better as compared to adults. Therapeutic uses of ultrasound. It's like I already told you that high frequency, high intensity focused ultrasound, HIFU. It is being used for prostate cancer. The patient, a suitable patient is taken. This is a HIFU probe. Patient is catheterized and the probe targets the ultrasound energy to the particular area which generates heat and the cancer is destroyed. Acoustic wave therapy. This principle is used in early stages of Peyronie's plaque. It has been found that in early stages or in some cases the plaque becomes softer and most of the patients and some patients may not need any surgical management. Acoustic wave therapy uses sound waves at lower intensities. At lower intensities, these sound waves will stimulate stem cell division and blood vessel development. It is used for erectile dysfunction. Earlier, there was extracorporeal shock wave lithotripsy. In this, we used to use single shock waves repetitively and fragment the stones. And the stones were supposed to be expelled naturally. A newer concept has come, which is burst wave lithotripsy. In burst wave lithotripsy, instead of giving single shock waves, the waves are given in multiple bursts. Because of this, the fragments that are formed are much smaller and hence they are much easily excreted. There is some, for truss biopsy, there is a new concept called fusion imaging. Fusion imaging, it can be either cognitive or it can be either computer aided. In cognitive, the radiologist assesses the MRI scan and he makes a mental picture of where the tumor is, and then during truss he focuses on that area. In software aided, the software does everything and it points to the site of the tumor which the radiologist has to go in and take the tissue. There is newer ultrasound called micro ultrasound. It uses very high frequency, 29 megahertz, and it has a very the spatial resolution is very high. It is 70 microns. This micro ultrasound is being used and it is also being compared with MRI for assessing prostatic cancers and also for taking biopsies. The future is artificial intelligence. So how can artificial intelligence help us in urology? The deep learning models are taking the images, processing them, and they are being trained to identify structures and also to identify pathologies. It is not so advanced, but in future AI will definitely help us in performing any scan or even in taking biopsies. Documentation. The patient details should be checked, the side of the pathology and the contralateral side, and all the images should be stored and handed over to the patient. So in brief, we have learned about the history of how it has come, where we can use ultrasound. We can use ultrasound for diagnosis, for therapeutic purposes, and the future of ultrasound, artificial intelligence is going to play a big role. Also, we have learned about the principles of ultrasound, that is, it uses the piezoelectric effect. We have learned about the output display standard, which shows us the mechanical index and the thermal index. Yeah, thank you.